to the trait track. I see some words. I want to see some faces. We need that energy, y'all. But I understand. I understand. Welcome to the 8th annual Warriors Conference. Hi, Miss Rosemary. And this is our second session of the trait track. We have been invited now for our third year in a row to conduct the trait track because we firmly believe here that education about sickle cell is not comprehensive if it doesn't include sickle cell trait. So we are most grateful, Sickle Cell Trait Education, to the Sickle Cell Consortium, Dr. Lakia Bailey and her amazing team. Sharonda is such a bright light, oh my gosh. But let me stop naming names because I know I'll forget someone, but thank you so much for being here. I am Tamia Austin. I direct the As One Foundation, where our mission is to empower families globally, delivering life-saving sickle cell education. And we are bringing you for the third year in a row, the trait track. So we have an awesome presentation today entitled The Kidney Connection. We have a wonderful two speakers, Ms. Richie Johnson, and some of you got to meet Dr. Maisha Pasante yesterday. She's with us again today. So without further ado, unless we think we should wait, Andrew, are we still letting people in?
Yes, I'm on.
Okay, we're still letting people in, but Ms. Richie, if you want to, you can go ahead and introduce yourself and we can start working on getting those slides up. How about that?
You want me to go first? I was thinking Dr. Maisha would go first, but I can. I thought maybe.
Well, Dr. Maisha, are you ready to go? This is so exciting. We got Mwape Miller all the way from the UK back with us again. She gave her presentation yesterday as a trait warrior.
Sorry, I thought Miss Richie was going first.
Okay, so Ms. Richie's ready to go. Ms. Richie's ready to go first. She won't be very long, so please stand by, Dr. Pasante.
I won't go anywhere.
Okay, all right, there we are. Okay, take it away, Ms. Richie.
Well, good morning. I am so happy to be here and I'm just excited that I was asked to come back again. This is my third time. Dr. Tamia Austin has been really the spearheader as far as getting us in the doors to sickle cell traits. So we're just excited to be here this morning. I am going to basically tell you about my 15-month journey with my son, who was a trait carrier, and I also am a trait carrier. And I want to try to share my screen. And
you got this.
Okay, if you say it. So I don't see my, let's see, my desktop.
Do you see the little green button already?
I did the green button.
Okay, then pick the screen that says presenter view for your slides.
Did you find your slides yet? Did you?
No, that's the problem. It's on my desktop.
So can you see your desktop?
Not when I sit share, no.
Okay, stop sharing and then share and then start sharing again and see what happens. Welcome everyone. Welcome everyone.
We all go through this, Miss Richie.
Yeah, and Andrew, we might need you to help.
Well, that's why I sent it in so that I wouldn't have to do this.
Yeah.
So what's coming up, it says, well, maybe I need to do this.
You have the slides open?
No.
Okay, so go ahead and open up the slides. And do you have any sound that's going to be in the presentation?
No.
No.
Okay, so you don't have to worry about that. So go ahead and open up the
Slides are
slides.
open.
All right, now go back to Zoom, hit the green button that says share screen, and now you should be able to see it as an option.
Welcome, everyone. You are at the right place. We're discussing the kidney connection. We're just working on our technology to get you the slideshow to go along with the great education you're going to get today.
Okay, I
About-
went back to share.
All right, and do you see the, are you using PowerPoint?
Yes.
Okay, do you see the PowerPoint icon?
No.
No. You have the PowerPoint open?
Yes.
Hmm.
It
Is
was.
there any way she can email them to you, Andrew?
Yes. Let me get the consortium's email address real quick for the tech support.
Andrew, you need the tech support email address?
I
Yeah,
have it.
the slides were emailed to, I believe, whatever the email was to pre-email the slides. They were emailed to that email last week.
All right, so I put the email address into the Zoom chat. You can go ahead and copy that and email the slides over, and then I will pull it up for you.
So while we're waiting for our technology to get together, you are here at the Trait Track. The As1 Foundation is the host of the Trait Track for the third year in a row. We are absolutely honored to present our sickle cell trait perspective, our trait stories, and we certainly welcome your comments and questions in the chat, both on Zoom as well as over in Hoover. And you can certainly visit the As1 Foundation's booth. I believe it's 308. If you want to continue the conversations, Ms. Ritchie is also on Hoover. So any questions, because this hour is going to go by fast. It already is going by fast. Questions for Dr. Pasante. You can definitely share your questions with both of them about this presentation today, or anything that we've discussed in the Trait Track. Tomorrow, Life Action Hydrate, 1 p.m. Eastern will be the final Trait Track session. And that'll be myself and Ferran Dozier, also joined by Dr. Pasante, talking about just that. So hopefully you'll join us back again tomorrow, also at 1 p.m.
I sent it over.
Okay,
Do you-
it's
Do you
sent.
want me to, do you want me to, at
Go on and
least,
get started.
what I'm thinking is, while we're waiting, maybe there was some, if there are any, I really would like Dr. Ritchie to tell her story first, because I start getting into the science and I just
Yeah,
don't.
yeah.
So I really
Dr.
want-
Austin.
Go on and just start talking. I did email.
Yeah, let's get
I do have a
started
question.
and then we can.
We do have a question though. Go ahead, Rosemary.
Yes. Hi, everyone. So my question was around blood in your urine. So I live with sickle cell trait, and for most of my life, when I go to the doctor and do the urine sample, they say, oh, you have a significant amount of blood in your urine. And then they just kind of dismiss it as it being that I have sickle cell trait. So I don't, but I've heard that that's not a normal kind of thing. And so I have not determined at what point I should urge the doctor to do something else. And my doctors have not seemed to know themselves.
Yeah, this is one of the reasons why we really need to do a lot of advocacy around this. We need to get education in the medical curricula and the nursing curricula, even at the undergrad level in the science classes. Ferran has done a lot of work at the high school level. Dr. Tamia has done a lot of work at the collegiate level. You're addressing the core issue that we're going to talk about today, actually. And that core issue is that really what we started with yesterday, benign is not, right? It's not really, really benign. The problem is that blood is a sign. So the reason they're dismissing you is we have a diagnosis in medicine called idiopathic hematuria. And it's a type of situation where there's some people that we don't know why, they just have blood in the urine and it never seems to cause any problems for them. But when blood in your urine is associated with trait, that is a sign of the exact pathology that trait causes. And that pathology can then lead to bad outcomes if we don't intervene. So that's why we're trying to change the thinking and create those, make sure that we start to intervene. Because what should really happen for you yourself, if you're not having any pain or any other symptoms, you need to hydrate. And we'll talk about more of that when I get into my slide deck. It's not a very long slide deck, but we'll talk about more of that then. And your doctors, if the blood is a lot, they should be doing IV hydration for you. You need to have an IV fluid flush because for two reasons. That means that there are dead blood cells clogging the vessels and the tubules, the various small organs inside of your kidneys are getting clogged. It means that things are breaking and those things need help getting rinsed out. Your urine is trying to rinse them out, and that's why there's blood there, but there should never be blood in your urine. Your body is supposed to absorb it back, right? But it's not, because there's so much, and it's not blood that's coming from inside of the system. More than likely, it's blood coming from your urine itself. Your kidneys themselves. And so the hydration would expand the vasculature so that those sickled cells, those stiffer, stickier cells can get through. And it would also rinse out the bad blood and help your body. And that is very, very important to prevent some of the things we're going to talk about today, some of the things that Ms. Ritchie is going to talk about today. So you're touching on exactly what is important. Yes, kidney stones do cause pain. Yes, kidney stones do cause blood. If all you had was kidney stones, again, you would still need hydration, right? Especially if those kidney stones are causing pain. And if it continues, you would be evaluated for something called lithotripsy or percutaneous removal of the stones. Something would be done. We don't just let the kidney keep getting damaged and not do anything about it. So that's actually the crux of the matter today, so you're bringing up exactly what it is we want to talk about.
Are we all set, Andrew?
No, I'm not seeing the email.
Oh, but okay.
I sent it. Yeah, I don't know what's going on.
I'm wondering if I can. I wonder if I can find. Did you change your deck at all from before, Miss Ritchie? Because I can.
I did.
Does anybody know the email address that we were requested to send our slides to?
I'm going to send it to you and see.
Okay.
There's a question about low potassium diet. Right. So I'm not sure why we're looking for the low potassium diet.
I just sent it.
But I mean, obviously typically it's more so not eating foods with high potassium that we recommend. So bananas and potatoes, for example, are very high in potassium. So you would tend to avoid those. However, sweet potatoes, yucca, so other tubers are actually good for sickle cell and sickle cell trait. So you kind of have to balance it. As far as having a low potassium diet, I don't know that we get these diet rages. I don't know that it's about having this particular diet or that particular diet, like a low potassium diet or whatever. I think it's more so about what's going on with your system. And so for some reason, if your body isn't processing your potassium properly, where you end up having too much potassium because the kidney is starting to have damage, then you would want to be avoiding the foods that would increase your potassium. And I think it's somebody named Jay Jones asked that question about low. I hope that answers that question. So what, Miss Ritchie, do you want to start telling your story?
Yes, I will. I was sending the PowerPoint one more time, but I can. Did
Yeah, after
Tamia get it?
you send it.
No, I
think
didn't get it either.
I don't know what's going on because it was sent twice.
Your
Okay.
system might not like all the action that it's getting.
Maybe
It's
not.
just too much activity.
Yeah, let's just talk to the people.
Okay, well, let me just talk to you. I had some nice pictures to show you, but let me just tell you my story. Shoot, I want my slides up. Prior to Chris's diagnosis with REMC, my life was full of joy and flexibility. My two sons, my grandchildren, and my mother were my life. I loved my nursing career, but looking forward to retirement. I had over 40 years as a registered nurse and spent all this time caring for others that I did not know. I did not have any pressure on my life. It was actually pretty easy. I had time to socialize with friends, play with grandchildren, and travel to various destinations. I had the flexibility to do anything that I wanted to do. On the other hand, Chris was a world traveler. And after retirement, we were planning to schedule a few trips together. I had set a date for my retirement and was really looking forward to traveling with Chris as he toured the world. As a child, Chris grew up with his older brother, Mark, in the suburbs of Houston. From a very early age, he had a very inquisitive mind and would explore things knowing he probably shouldn't, and was always willing to face the consequence. He and his brother were very close, but did have their moments of disagreement. Growing up, Chris was extremely competitive. He enjoyed basketball, football, baseball, and he even loved fishing. And of course, he had to catch the largest fish, or there would not be any peace in our household. He was a talented athlete, and he made a significant contribution to basketball, football, track, lettering in both football, and he was awarded an all-district running back in his junior and senior year in high school. He graduated from Clements High School in 1991 with goals in mind, hoping to have a bright future. He went to Southwest Texas State University for 1 year, and after that, he was recruited to play football at University of New Mexico for the Lobos. He graduated from there in 1997 with a Bachelor of Business Administration. He was on top of the world. He landed his job that he loved so much at Shell Oil. And this is when our 15-month journey began in June 2011. Mind you, I am a trait carrier as well as Chris. Chris was perfectly healthy. He complained of having blood in his urine, and he presented to the emergency room. There we go. Thank you. That's my baby. So we presented to a local hospital, and a CT scan was performed, and Chris was informed that there was a spot on his kidney 7 centimeters in diameter that was suspicious for cancer. My body went limp. I tried so hard to process what I had just heard. I could barely speak. As I looked at my son on that stretcher, he neither moved nor spoke. I felt as though this was a bad dream, and when I woke up, things would be okay. But instead, I had to pull myself together and face the fact that my son had just been diagnosed with cancer. Over the next 15 months, I was not only his mother, but I became his advocate, his caregiver and gatekeeper. Little did I know that when I chose nursing as my career, that God was ultimately preparing me to care for my youngest son. I felt helpless at times because there was little that I could do to help alleviate the pain that Chris endured. There were times I retreated to a quiet place and where I cried and then regrouped so that I could be strong for him. I had to be strong so that I could encourage him to keep fighting. My heart was breaking as I tried to do everything to relieve him of his pain and provide him with a sense of normalcy. As my son's caregiver, I assisted Chris in making informed decisions regardless of his health care by explaining various treatments in layman terms. I established a relationship with the medical professionals and would often ask questions so that I could be knowledgeable about the next course of treatment for him. I kept him calm so that he would not become depressed and give up. He would always say, "Mama, I'm tired." I had to keep family members updated. When my son was in pain, I had to speak up and demand that the physician was called so that he could be given a different type medication to minimize his pain. When my son was throwing up on the second day of chemo, I had to ask that they hydrate him every Monday. In other words, you have to stand firm in what you believe the best quality of care is for your loved one. And you can hold it right there for me for a minute, Tamia. During these 15 months, I was affected by the uncertainty and strain associated with caring for my son after being diagnosed with such a catastrophic illness. It required me to drastically reconfigure my role as a mother. My son, who was perfectly healthy, had the sickle cell trait, and now he has cancer. That sickle cell trait became the factor of. I assumed new and unexpected responsibilities. I no longer thought of myself. I had to focus entirely on meeting the needs of my son. From day to day, I didn't know what to expect. Any moment, Chris would become short of breath or have excruciating pain or excessive vomiting, which often caused us to go to the emergency room. There were times that we would go just for chemotherapy and then we would end up in the hospital. I initially requested a 12-week personal leave so that I could be and care for my son during this time. And after 2 months of being with Chris, I realized that our journey was far from over. He required weekly chemotherapy and various other appointments were scheduled throughout the week, and someone had to be with him. I didn't know from day to day how he would feel. His condition was not improvement, and my 12-week leave would be ending. It was physically impossible for me to juggle work hours and meet the needs of my son. So I made the decision to leave my nursing career after 40 years so that I could adequately care for my son every step of the way. The decision that I made was actually the best choice because it enabled me to focus entirely on Chris and give him the support and encouragement that he needed while fighting this life-altering illness. Our life was like an emotional roller coaster. I felt throughout my journey with Chris that I didn't know from day to day what my emotions would be. I was shocked and in disbelief when my son was told that he had a 7-centimeter tumor in his kidney, suspicious of cancer. I even felt guilty because I am the one that has sickle cell trait. And if it wasn't for me, my son would not be going through this. I became frustrated while trying to resolve issues with the insurance company and fearful that his treatment would be discontinued because he was coded as this being a pre-existing condition. I became sad and felt helpless as his mother because there was not anything that I could do to rid his body of this beast. On September the 20th, 2012, my son passed away. I was broken in every sense, financially, emotionally, and spiritually. And of course, I was deeply brokenhearted, for my life will never be the same. So while Chris was receiving his treatment at MD Anderson Cancer Center, he noticed a lack of advocacy. And this is Chris with one of his nurses. And he wanted to start a foundation that would focus on REMC. He became tired due to the progression of his disease and was not able to start the foundation. However, in April 2013, next slide, please, the Chris C.J. Johnson Foundation was formed, and our mission to find a cure for renal medullary carcinoma worldwide through awareness, education, and research. The primary focus is on individuals with sickle hemoglobinopathy, such as sickle cell trait, who may be at risk for this rare and aggressive form of kidney cancer. In addition, the foundation offers emotional, spiritual, and financial support to individuals diagnosed with REMC and donate funds annually to MD Anderson Cancer Center to advance REMC research. Next slide, please. These are just some of the faces of REMC. We have Andre here, who's in his mid-30s. He was a captain in the Army and doing very well. I'm proud to say that he has now been free of cancer for the past year. And then we have Micah, who was in his first year of college, noticed blood in his urine, and he's still fighting this battle. We have McKenna here, who was diagnosed at the age of 15, is now 21. Next slide, please. And this is Fanina, who's over in Greece. She was diagnosed at the age of 15 and is still battling cancer. And then this is my little heart, Caleb, who was 9 years old and he's now 12, and he continued his fight with REMC. And then we have Nicholas, who was 12 when he was diagnosed, and he lives in Colombia with REMC. There is hope. Next slide, please. Right now, the University of Texas, because of our advocacy work, has three active clinical trials for the patients. In 2012, Chris did not have any treatment modalities that were specifically for patients with REMC, but now we do. Next slide, please. So despite the fact that REMC has been described in the medical literature for over 2 decades, many questions remain unanswered, and addressing them is critical in order to optimize the future care of this patient population. Next slide. And this is our REMC support group. We were the only foundation that now have a support group specifically for patients with REMC. Is led by a peer-to-peer, and it gives them the opportunity to meet every Monday. Once a month, every second Tuesday, to discuss their feelings and just share their ideas. And it has just been a great thing for the REMC community. Next slide. So advocacy is so important. It's important that you go to lobby in Austin or in DC or whatever your state capital is, form partnership with As One Foundation, the Kidney Cancer Association. It's better to have more together. The louder your voice, the more that you can get things done. And of course, through community health fairs. And then we have our fundraising event, Keeping It Renal Run Walk. Next slide, please. That is held every year. This is a great opportunity that we all get together. And the past 2 years, it has been virtual because of COVID-19, but that is great because we have been worldwide and we've just had a beautiful turnout. This is Gabrielle. This is Chris's daughter, who was 6 years old. It was because of what Chris told to Dr. Tanier, who has his arms around Gabrielle. He says, "You are world renowned. I need you to save me so that my 6-year-old daughter, I can see her graduate from high school. And many of our RAMC patients face health disparities. You can go to the next slide. Many of our RAMC patients face health disparities due to persistent systemic unjust policies and practices, which increases the group's risk for poor health and limited access to quality care. As a nation, we can no longer stay silent and accept the disparities that exist in education and healthcare. African Americans with sickle cell trait are afflicted with REMC more than any other ethnic population, and yet they are denied access to institutions that have cutting edge research because of their insurance coverage or lack of. Everyone should be treated equally, and advocacy is necessary to create change. I am a warrior, and I will keep fighting until REMC has been cured. Thank you.
Thank you, Ms. Ritchie. Thank you so much for sharing your story. That has been expressed, that sentiment has been expressed in the chat. I've heard that story and I'm just as emotional. Thank you so much for sharing that real life experience of RMC, the rare cancer associated with sickle cell trait. I'll take a peek over at if there are any questions in Hoover, but Dr. Pasante, please, we're at the halfway mark, so jump on in and get your slides ready to go.
Yep, I'm ready.
Okay, well, we're ready for you too. Take it away. Well, let me just.
There we go.
Okay, just one question, and I probably should wait.
It's okay, go for it.
I saw a case study a few weeks ago about sickle cell and a rare form of kidney cancer. I forgot the name of it. I know the one you're talking about. Question is this truly a risk factor for individuals with sickle cell trait? And is that also a possible risk factor for all sickle cell trait plus another trait status?
Absolutely. This disease is this disease, renal medullary carcinoma, is almost exclusively in sickle cell trait, and whatever is not in sickle cell trait is in sickle cell disease, but very rare in sickle cell disease. It's primarily in sickle cell trait. And that would be because that's kind of what we're going to talk about now. So that's kind of a good prompt into what we want to discuss. So basically, can you guys see my slides yet? You can see the slides?
We can see them. And
okay.
They're big.
Okay, good. Good. All right. So how do can I flip over it's not letting me advance. I just want to advance. There we go. Okay. So now I can push it over. Okay, great. All right. So I'm Dr. Maisha Basante. Just call me Dr. Maisha. I'm here as I'm a family physician, and I work with the What's Account and the organization that Ferran Dozier has established. We have been doing advocacy for sickle cell trait for a really long time. Health disparities, like what Ms. Ritchie mentioned, is one of my very big motivators. I am trying to help with the people that people don't want to help with, and to teach people what people aren't learning. When you have something that affects 5 million people in the United States and 300 million people worldwide, and is the biggest quantity of genetic diseases out of all the genetic diseases, it's mind-boggling that more attention is not paid to it. The more attention is paid to things that are far more rare. Without naming names, because those things need attention as well. But for example, there's one statistic that the funding for CF is 8 times the funding for sickle cell research, in terms of the number of dollars that are given towards it. So that's why we don't know, and people are still asking the question that was just asked. It should be well known that if you have sickle cell trait, you can develop renal medullary carcinoma, albeit it's rare. However, you should know that a boy with sickle cell trait is far more at risk than a girl, although both can have it. You should know that if you keep seeing blood in the urine, then that needs to be followed. And honestly, imaging should get done to make sure. So there's not screening per se. So Dr. Mosul talked about this in a previous conference that we all were in, that they've been going back and forth about whether or not it's worth it financially and medically to do, and also the cost of the emotional toil on the patients to do screening for renal medullary carcinoma because it is considered rare. However, on the flip side, if you do have blood in the urine, then that's something that you should get screened for. You should get at least an ultrasound or a CT scan that will tell you whether or not there's a mass there. So, and ultrasounds are relatively non-invasive and relatively inexpensive, despite your insurance, and even if you had to pay for it out of pocket. So it's not that big of a deal to do. And so that is just a very, very, very good question to begin with. So the purpose of my presentation today is to make sure that everyone develops an understanding of the relationship between sickle cell hemoglobinopathies, exertional sickling, renal compromise, and renal medullary carcinoma. All of these things are actually quite connected. So I'm gonna talk a little bit about the link between cancer and sickle cell trait. We've kind of done that already. We're also going to explain why sickle cell trait, exertion, and kidney injury are all connected, and then how that can develop into the cancer. And we're going to delineate some of the best practices for some of the precursors or the harbingers that you may be headed towards renal medullary carcinoma or other types of renal injuries. So hypostenor and hematuria are some terms I'll explain to you, and then talk about, well, I'm not going to be able to talk as much about the treatment for renal medullary carcinoma and what to do in the later stages. That's more Dr. Mosul's area, but I'll kind of briefly touch on it. So to begin with, basically, when you do, some of the studies have shown that when you do high intensity exercise, that is actually a big risk factor for developing renal medullary carcinoma when you have sickle cell trait. So what is high intensity exercise? High intensity exercise means you're not doing anything and you burst onto doing a whole lot. You do a lot of repetitions very quickly of something. It can be weights, but especially cardio. You run a marathon very fast. You know, you just go into it. And you don't very slowly work your way into the exercise. You have to warm up when you're going to exercise. You have to make sure that you're warm up, drink up, rest up. You know, I was going to say it. Yeah. I saw your face. Yes. I was trying to resist the temptation, and then I couldn't.
You got
it. And so that is a Dr. Tamia special, warm up, drink up, rest up. And so basically, high intensity exercise is the opposite of that. And these are the conditions that we put athletes under, especially in preseason football training. They haven't been doing anything, then all of a sudden they're running death drills. That's high intensity exercise, and that puts you at risk for developing exertional injury to the kidney, and that exertional injury can then lead to the carcinoma that we've been talking about here today. And so you aren't used to exercising and your doctors told you you're overweight, and all of a sudden you're just going to solve the problem now. That's high intensity. You want to do a very few repetitions for a very short period of time and hydrate very well in the beginning, especially if you haven't been exercising at all. And then you can build on it slowly, and that doesn't put you as much at risk as high intensity does. So of course, the recommendation is that you want low to moderate intensity exercise. You want to reduce complications related to the sickle cell hemoglobinopathies. You want to monitor individuals with sickle cell trait, and this is more for trainers and doctors, so that you're watching to see if they're getting fatigued, if they're getting dehydrated. So when your kidney already needs a lot of water when you're exercising. It doesn't matter who you are. But that's even more so the case when you have sickle cell trait. So when you have sickle cell trait, okay, you can get dark urine, flank pain, and muscle pain. A lot of these patients get dismissed. You have a urinary tract infection, here's your antibiotic, drink some water, have a nice day. That does not work. If you see that your urine is getting dark, your urine should be light yellow to clear, especially when you have sickle cell trait. When you see that your urine is getting dark, then you know that one of two things is in that, or three is in that urine. But the two things that we're most especially worried about are the blood and muscle tissue breakdown products. So blood or blood breakdown products and muscle tissue breakdown products can be in that urine. You're getting, your flank is that area at the smallest part of your waist and then moving slightly towards the back. That's what we call the flank, and that's where your kidneys are located. When you have pain in that area, that means your kidneys are not happy. Whether it's an infection, a stone, or God forbid, a mass. Muscle pain, and that can be anywhere on your body. Your muscles will be aching and hurting, and even your bones. And again, that means tissue is breaking down. When your tissue keeps breaking down over and over, and your body has to keep repairing it over and over, that is when you develop cancers. And it doesn't matter what the cancer is. Repeated injury to any tissue, repeated breakdown of the tissue, which then has to be repaired. Sooner or later, your body is going to repair that tissue incorrectly. That's why if you live long enough, you get cancer, right? That's why we test older people. I used this example yesterday for colon cancer. And as you get older, you have more uterine cancer, or else just the benign fibroid tumors. Because the more times you have to repair and replace tissue, the more chance that that tissue is going to be, your body is not going to do it correctly, because that's part of the aging process. And the DNA is going to have breaks or deletions or mismatches, and then you're going to develop a cancer. So those are patient characteristics that could mean you're having rhabdomyolysis, which we talked about yesterday, or could mean you're having a urinary tract infection that is actually starting in your kidney that can lead to something called pyelonephritis and even something called sepsis. Pyelonephritis is when your kidney is full of pus and bacteria, and you can get very sick from that because that can then go into your blood, make your heart rate go too fast, and your blood pressure drop too low, and you can actually die from that. So it can start off as a simple kidney infection. From people that don't have trait, usually a kidney infection is not that serious. We give you some outpatient antibiotics, tell you to drink some water, go home and rest, take a couple days off work, and usually you're fine. But in someone with sickle cell trait, when you get a kidney infection, you can end up in something called urosepsis. And that could, of course, lead to death. Or you're going to keep those kidney infections happening over and over and over again are indicative of damage to your kidney, which again leads to the renal medullary carcinoma. Okay, I did something and I'm not able to advance. There we go. Okay, let me go back. Okay.
We have a couple questions too, if you want to.
Okay, all right. So this is just an article by Dr. Naik, Association of Sickle Cell Trait with Chronic Kidney Disease in Albuminuria in African Americans. So she found that sickle cell trait is actually associated with chronic disease and protein in your urine at a higher rate in African Americans. So we know, and we've known that African Americans get more kidney damage, but everybody's like, oh, why? We don't know. Maybe they just don't eat right. Who knows? But this is one of the reasons that contributes to chronic kidney disease in African American patients, especially, or any patient of any race with sickle cell trait and sickle cell disease. So I want to pause here on my little graphic. This graphic is showing you the blood vessels that are going into your kidneys. And down here, you can kind of see a cartoon representation where your renal pyramids would be. This is your medulla. And the thing is, nobody really gets cancer here. It's very rare because there's no reason for this to have a problem, except if you have sickle cell disease or sickle cell trait, and especially sickle cell trait. You see these tiny vessels going in? The blood is getting stuck there. And when that blood gets stuck there, it breaks down the vessels die. When the vessels die, you basically get the equivalent of gangrene, but in your kidney, right? You have tissue that's dying and turning full of pus. And if you don't get fluids in you to rinse that out, then of course you're going to have a big infection in your kidney. And if that keeps happening, that's when you get the protein in your urine, the dark urine, the pain, and the cancer can eventually develop after time. And usually, though, with renal medullary carcinoma, you can get that as young as 9 years old in a patient with sickle cell trait, especially in the boys. So if you have a boy with sickle cell trait, you need to make sure that his urine is getting dipped for blood. And if blood is found, that he's getting imaging to look for the renal medullary carcinoma. Your girls as well, but even be more aggressive about your boys, because the expected life for for renal medullary carcinoma is 12 to 18 months from the time of diagnosis to the time of death. If you're fortunate to get to one of the centers that are very experienced, you can outlive those numbers, but you could lose your kid within a year. And that's devastating, as we just heard from Ms. Johnson. And that's kind of why I wanted her to go first, because people need to understand the human side of this, not just the scientific side. So what she talked about was that, back to the article, was that sickle cell trait was associated with increased risk of CKD. We talked about that. And how did they know? There's something called your glomerular filtration rate. And those little organs are here in that same little area. And they are the ones that tell your body how much salt, protein, everything to let out into the urine, and how much to send back into the body to keep everything in its proper balance. Well, when you have sickle cell trait, your kidneys aren't doing that anymore. That's why you get blood and protein in your urine. And at the same time, your urine will be not concentrated. It'll be poorly concentrated. So you will look overhydrated to the doctors when in fact you were dehydrated. And that way that your urine looks is one of the reasons they think you don't need fluids when you actually do need fluids. It's a paradoxical finding, and we have a lot of those in medicine. So it's not hard for a doctor to grasp it if someone teaches them about it. And that's what we need to do. We need to support these, we have a big series at our company, Inscription. We have a 5-part series to educate everyone, the community as well as doctors, about sickle cell trait, how to treat it, all the different things that can happen, like the kidney injury that we're talking about now. We've put together a lot of the literature and education that's out there. And so we've got to get this message out so that we can save the Chris Johnsons of the world. And so the decreased glomerular filtration rate and the decline in albuminuria, those findings showed that when you have sickle cell trait, you're at a higher risk of sickle cell disease. So what is hypostenuria? Before I tell you what to do about it, hypostenuria, there are 7 nephropathies, meaning damages to your kidney, that can happen with sickle cell trait. I'm speaking about the trait, and it's more in trait than in disease. So you say, why? Why wouldn't it be more in disease? Trait is also its own thing. It's not just a less severe sickle cell disease. It is a less severe sickle cell disease typically, but it's also its own thing, because in trait, your cells are stiffer and stickier. In disease, you have a lot more of the folding into that sickled cell. You may not get that in trait. That's also why doctors miss it, because you guys are in the corner. That's why I'm looking to the side. I should put you at the top so I'll look up at you. Sorry, is that better? Okay, so basically in trait, your cells are still round, but they don't bend like they should. So they don't form that sickle that they're looking for in the peripheral blood smear. They stay round and your cells are sticking together. And so they're clogging all the tiniest vessels in your body. That's why, like we heard yesterday, people with trait especially get the dactylitis, the swelling in their hands and feet. Their joints will hurt or itch or burn. Their bones will ache, but you can't find anything wrong with the bones because that's where you have tiny vessels. They have eye problems. They have problems in pregnancy and increased miscarriage and increased problems with even getting pregnant. So hypostenuria is one of those problems where because those vessels are dying off in the glomeruli and in the small organs of your kidney and the renal pyramid, which is where the various tiniest blood vessels are in your body, except maybe the eye, your body is not able to concentrate your urine, meaning put the electrolytes that should not be in your blood into your urine. So they're staying in your blood. So your urine is hydrated and your vessels are dehydrated. Why? You have way too much salt and potassium and everything else in your body still at that moment that should have gone out into your urine, but it stayed in your body. And so that's why you have to have fluids. You need to increase your oral hydration, so drink a lot of fluids, and you need to have IV fluids. And one of the studies, and this study was done back in 1969, where he showed alkaline water and IV hydration helps patients with sickle cell trait, as well as oxygen by nasal cannula. The other problem is your oxygen levels will be completely normal, but because those cells are stiff and sticky, they're not actually getting the oxygen. They're not letting go of it to get to your tissues. They're not doing their job. And so you need more oxygen into the system to like trip that system, just like you need more water to trip the fact that you have the hypostenuria. And so, and that's also why you have the blood, because things are breaking down and that's going right out into the urine. So the last slide I wanted to show you, this is a image of the inside of your body. If you laid down flat and someone just sliced you in the middle. So up here in the upper left corner, that's your upper left hand corner, that's your liver, just for reference. So if you go down, you see the big white, the whitest white, that's your bone, and you see your ribs going out along the periphery. So that's your vertebrae. Okay, so between that liver and the upper left and that big, beautiful vertebrae in the dead center bottom, that is a kidney. If you look to the opposite side of that big, beautiful vertebrae, that is another kidney. You can see the difference between those two kidneys. The one on the lower right-hand side of your screen, that is a normal, healthy kidney. Well, as far as the image, it may not be healthy because I don't know the blood work, but it's basically a normal, healthy kidney. On the other side is a kidney that is racked with renal medullary carcinoma. That black area there is where there's so much blood going to that mass. So one of the reasons cancer makes you tired is the mass that it's forming. All of your blood and nutrients go to that mass. And it's full of blood vessels. And it's happy and healthy for a tumor. But you're sick. So I just wanted to make you kind of get a visual so you can see why that's where you'd have your pain. And that's why you see the whole kidney is swollen and it can't do its job. So there's at least two masses there where those arrows are pointing to. And that's kind of the end of this particular slide deck. So I'll stop sharing and answer questions.
Thank you so much, Dr. Basante. This is always so interesting, no matter how many times I see this. I'm so happy to see that there are people thriving in spite of RMC, as at one point it was extremely fatal. But we have some questions because our members here are looking for some answers. One says, I try everything and I can't alleviate the blood and protein in my urine. Nothing shows on imaging other than cyst on left renal pole, but the doctor says it's insignificant. I am scared because I get stomach pain and back pain, nausea, vomiting with hematuria and proteinuria. Doctors claim they don't know why because I don't have high blood pressure or diabetes. How do I get doctors to listen? Another,
Richie, as a nurse, how do you get us doctors to listen?
I'm just gonna get through these because, like I said, Dr. Basante, you can hit a lot of these in
Not
one
easy.
reply, especially because we literally have 6 minutes left before we have to go to the next session. I think she's saying they claim I should be benign even with beta thalassemia trait, but my urine looks like T. And then another comment is, so do you have, okay, no, that was a comment between other people. Why would someone have a normal GFR with significant hematuria and proteinuria? So that's it for the questions.
I'll go in reverse. Why would you have a normal GFR with significant hematuria and proteinuria? Because you have to lose 85% of your kidney function before it shows up. Like you have to lose a ridiculously high percent of your glomeruli and the smaller organs within the organ, is the best way I can put it. You have to lose like 85% of your nephrons before your GFR shows. So by the time your GFR shows, cat's out the bag, game's over. We can't wait that late. And I'm sorry I'm talking like that, but it just really upsets me at knowing the science when doctors say things like, oh, that's insignificant. And it really means they just don't know about it. And in defense of my colleagues, they just don't know. They've been trained that it's not important because we don't know what it is. The same way we took out tonsils and appendices, and we love to take out gallbladders before we look for other options. Because we thought they didn't matter, but they do functions, right? The appendix is part of your lymphoid system to help keep you healthy. So as well as your tonsils. So as far as what can you do about the protein in blood and urine that they are telling you is insignificant? You absolutely have to hydrate, support our causes. Inscription will be eventually opening a practice that hopefully we can help some of you guys with. We are doing consultations. The website is up. I probably should put that in the chat.
Please put it in the chat. Yeah.
Get someone to put it in the chat. We are going to be starting to take consultations again. I travel a lot. It's Inscription. What's my website? One of you put that in the chat for me. I can't remember my website. And so one of my team will put that in the chat for me. And so you have to hydrate every single day. Anybody needs half their body weight in water. You need more than that. You probably need about 75% of your body weight in water. Coconut water. You need good proteins, beans, things that you can process more easily. Red meat should only be occasional, say once every month or every 2 months. You need proteins that you can process, but you need to focus on your fruits and vegetables. You need to do slow graded exercise like we talked about today, because exercise actually opens your vasculature. So you need things to make your vasculature more plump and to help hydrate your system. And what was the other question? Oh, Miss Ritchie, how do you get doctors to listen?
Actually, the nurse has to be an advocate for the patient. The doctors really don't listen majority of the time, but it is the patient that normally is the advocate that really will coach the physician and basically express their concern in order to get what needs to be done.
Good doctors really do listen to the nurses because we know that they spend the most time with the patients. And when you have a good nurse, like I know Miss Ritchie was or is still actually, then you really have hit the jackpot because she's going to make your life a lot easier. The other thing is sometimes if you have family doctors tend to be more open-minded than other specialties. And so if you have a good family doctor that is willing to listen to you, we have an entire slide deck on the indices they can look for, the actual lab work they can do to then provide to hematology. I had a big win recently with a patient. She's actually a white woman with alpha thalassemia trait who's just in a lot of pain. And they kept giving her iron supplementation unnecessarily, wasn't helping her. And the hematologist actually agreed that she had alpha thalassemia trait, which I found because I knew what to look for. And so we're able to take care of her. She does have an enlarged spleen, which can occur with alpha thalassemia trait, with alpha thalassemia, but they don't think it happens with trait. But now I have proof that it does. And so when you can bring some of the case studies and some of the data, we are evidence-based. Show me the money, show me the data. So some of the articles that are circulating on social media can sometimes be your friend. The great review articles can also help you when they see a review article that shows a body of data that says, wait, this actually is a problem. You can get them to think twice about what they may have dismissed, but you have to do it in a loving, respectful, gentle way that says, I'm sure that you really do want to take good care of me. So I'm just going to help you do that. But if you kind of come in like Rambo and you treat the doctor like, yeah, I know you don't care about me anyway, that's what you're going to get back. So you kind of want to approach the doctor from a perspective of, I'm sure you entered this profession to save lives and to make my life better. And maybe no one ever told you about this. So I know a lot of the doctors don't necessarily care. Is there an I in it? Is there an I in the inscription?
Oh, that is,
IN? Okay.
I'll take care of that. Yeah.
Okay. And so is it supposed to be IN or just N? Oh, you
And
changed it. It says
I put
IN.
it in the I
Look
put
at what's
it
in the chat.
chat.
You guys verify which one is right.
Okay. And with 1 minute to spare, I'm gonna say thank you to both Dr. Pasante and Ms. Ritchie.